Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning. So I'm delighted to be here with our GP advisor, Dr Ravi Ramanathan today. Welcome, Ravi.
Thank you. Thanks, Pat.
Thanks very much for joining us. And GP advisor means Ravi provides us with a lot of advice on a lot of different issues over every year to MIMS Learning, to MIMS and GP Online. But he also has some particular roles as a GP appraiser, and you're also involved with a vocational training scheme locally, as well as many other strings to your bow. But you've got a really good appreciation of how appraisal works and the sort of the detail that's involved. So that's what we wanted to talk about today. We did talk about appraisal approximately 18 months ago, I think. And it seems from chatting to you earlier today, Ravi, that things have actually changed. Even in that time period, there's been a reasonable amount of change in the appraisal process, what's required, the type of thing that is talked about during appraisal. So could you perhaps talk to us a little bit about that?
Okay, so since the pandemic, there has been a change in emphasis of appraisal.
Yeah.
I think appraisal was very pre-pandemic. It was very focused on clinical knowledge and keeping your clinical knowledge up to date. And during the appraisal, it obviously moved to a big emphasis on maintaining your clinical knowledge, but also on maintaining your resilience and well-being, and being aware of your resilience and well-being and dealing with aspects of that. I think even when we talked in 2023, we talked a little bit about that sort of pivot to resilience and well-being. But I think that has become sort of more embedded since we last spoke 18 months ago. And now the latest biggest change is that there was new guidance on good medical practice from the GMC, which was released in January of 2024.
Yeah.
And obviously the appraisal process is based on good medical practice and the guidance within good medical practice. And obviously the appraisal then links to revalidation and also your license to practice from the GMC.
Yeah.
And the main difference that occurred in January 2024 is that the domains that are on your appraisal form have now changed.
What's the change been? There were 4 domains previously, and are there still 4 now?
Yes, so there's still currently 4 domains, but they've been labelled in a different way.
Okay.
So the first domain is knowledge, skills and development, which we're all very familiar with. That's keeping up to date with your knowledge and demonstrating that you're able to use your knowledge and skills in managing patients. They do contain elements, large elements of the previous domains, but the second domain is patients, partnership and communication.
Right.
And here there's a greater emphasis on working collaboratively with patients and also on areas such as reducing inequalities and also working in partnership with patients and also, involving them in management decisions and so on.
And presumably elements of that were in the previous domains, but this one is actually kind of like the title's changed to reflect the importance of patient partnership.
Yes, so there's a greater emphasis placed on the partnership model with patients, and these concepts have always been there in primary care, but I think they're kind of more formalised and written down to increase their importance. And the third domain is colleagues, culture and safety.
Right.
And here there's a greater emphasis on creating a equitable environment, within primary care, of treating colleagues kindly. Now, it's obviously it's very difficult to define what that actually means, but in a way you've got to try and demonstrate that you're creating a culture for patients, you're creating a culture for your colleagues, you're creating a culture for your teams.
Is this kind of on the basis that if you treat each other with respect and compassion as colleagues, then you're that much better able to treat patients with the same values?
Yeah, it's that basis, but it also means that people can, work more effectively and well within a team,
Yeah.
that you're harnessing everybody's strengths, you're not discriminating against people. And this is discrimination in every form that we understand it. So race, gender, physical illness, sexual orientation,
Yep.
all of those things. So I mean, it all makes perfect sense, because if you can create this, then you're really harnessing the skills of your entire team, and
you're going to get a better outcome
come for patients.
for patients. Yeah.
Yes.
Great. So that was number 3, right?
Number 3.
Yeah.
And the last one is trust and professionalism,
Okay.
which was there before, but I think they've emphasized the word professionalism. And it's just professional behavior and ethics. And again, this links into, what could be considered professional behavior being a bit broader
Right.
than just medical ethics. Again, it links into areas such as discrimination, equitable treatment of people, as in the whole of society. I think, there's been, sexism and racism and that's all coming into the forefront, and it's sort of demonstrating that you are aware of these things and that you're somehow tackling them.
Yeah. Yeah. That you've got them on the radar.
Yes.
And does that apply to your kind of dealings with other parts of the health service and, for example, integrated care boards and the way that you deal with secondary
Yes.
care colleagues or mental health colleagues or whatever?
Yeah, all your interactions. I suppose traditionally medicine was very hierarchical and maybe a bit paternalistic and so on. And, we're sort of moving into what is becoming societal norms. That they consulted very, very widely before changing the good medical practice. So there's huge input from staff, doctors that are working, and this is what they wanted. So one of the slight things is that people now struggle. How do I demonstrate? I mean, for instance, how do I demonstrate I'm kind to my colleagues?
Yeah, that's
so
interesting question.
So I think there's much more latitude in what you can present in your appraisal to demonstrate all these aspects. And personally, I think case reviews are very important in this, because you can demonstrate how you're doing a lot of these things by the way that you've dealt with patients and with colleagues when you're, are helping to manage patients.
Yeah.
But also, things like if you've changed working practices at the surgery, or if you've, or even if you've done educational content around some of this change agenda, then, putting all that in. So, I mean, in a way, I think appraisals become much more flexible.
Right, okay.
Which has its advantages and disadvantages. I mean, some people like the flexibility of demonstrating these capabilities in a way that they choose. So, and I think we've just got to all become a little bit more flexible in the way that we think. And certainly I'm sure a lot of appraisers are becoming more flexible in what they consider to be appropriate evidence.
Yeah. Yeah, that's what I was just about to ask. If I was a GP going into my next appraisal and thinking about my evidence, I've now got a kind of like a wider scope of evidence to draw on, by the sounds of it.
Yes, and if you're unsure, then your appraisers can guide you in this. So, I mean, I think we've just got to think a little bit more broadly than just thinking, am I demonstrating that I'm clinically safe? I mean, that's obviously extremely important.
Yeah.
And still should be the major focus, I think, of the appraisal. But I think we've got to think a bit more laterally about how we're interacting with the system, interacting with the patients a little bit more, and try and demonstrate some of that as well in the appraisal.
Okay, well, that's really, really useful. And we were talking earlier about, obviously, there's keeping patients safe by being clinically up to date. That's important, but it's also important to keep patients safe by looking after yourself. That seems to be an element now of appraisal.
Theoretically, it's always been there, but I think there's a greater emphasis, and logically that has to be the correct approach, because if you're at risk of burnout, then somehow dealing with that is very, very important for you, but it's also very important for the patient. But I think when we look at material, we would find, material that's not purely clinical very valuable to the appraisal process.
So could you tell me a bit about the sorts of things that people might bring?
Yes, so examples would be, for instance, some form of resilience training, maybe in a group activity at the surgery, which either has built on resilience or even leadership, some leadership activity, because increasingly GPs are leading teams of people. I think you just got to think very broadly. Anything that improves your personal resilience is valid, as a way of demonstrating. Or if you've helped a colleague in some way, maybe writing up a case review based on, how you assisted them. Say somebody had a GMC complaint and you helped them through that process. The advice you gave, the moral support you provided, or even a member of staff, how you assisted or helped them or helped the team, understand stresses that they're encountering and how those could be reduced. So you've got a lot of latitude.
So it is a little bit of a changed picture then.
Yes.
And do you think it's going to stay the same? Are there going to be further changes in the next year or so?
I think it's likely to remain the same. I mean, I think the role of the GP, if you're a partner, for instance, has changed very significantly, and it's going to continue to change with the addition of additional roles, staff, and so on. So you're very much coordinating and leading a team, and probably GPs are going to be involved a lot more in training and teaching and monitoring, and so all those skills are going to be important to demonstrate.
Yeah, so the sort of coaching and mentoring skills and all those, and management skills, all those kind of skills are going to come into the picture.
Yes.
Yeah, really interesting.
So we've moved from this very much 50 hours of clinical certificates to this kind of much more holistic approach, to what being a doctor is, and also thinking about some of the softer things that we always did without hard measures, but somehow trying to show those in appraisal.
Yes, and trying to value appropriately the more ephemeral things that are harder to measure, but are really, really important in practice.
And generally, even medical education, obviously the academics is very important, clearly, but they are trying to instill this in younger doctors.
Yeah, sounds like a good move, definitely. So we did a seminar back in October with a small group via MIMS Learning, and it was about appraisal and revalidation. And we had some specific questions that came up as part of that. Would it be okay to run through a few of those in case anyone listening has a similar question and would like to know the answer? There was a question around, if you're a newly qualified GP or a returner to practice, how do you get an appraiser?
So in every area, there is what's called an appraisal team. And so what you need to do is identify your local appraisal team and then contact them. Essentially, you should be able to find that relatively easily, because you will be on something called the performers list in any one area.
Okay.
And there is an appraisal team that looks after the people on the performers list.
Who are the appraisal team attached to, and what organisation?
They're part of NHS England.
Right.
But every area has a clinical lead, plus their administrative support. If you actually don't know who your appraisal team is, you can actually contact the GMC.
Okay.
And they will tell you that every person has somebody called a responsible officer, the clinical head of the appraisal team. So everybody has a responsible officer, and through the GMC you'll be able to get the contacts of your local appraisal team.
Right.
But generally speaking, they're very good. They normally track you down. It's usually the other way around.
Okay.
And contact you for appraisals. But if you haven't heard...
that's what to do. Okay, great. And is there a minimum number of sessions that you need to undertake for an appraisal in the UK?
Okay, so there never used to be a minimum number of sessions, but now they're saying that you should be doing enough sessions to ensure that you're keeping up to date.
Right.
So if you're doing less than 40 sessions a year,
Right.
so it's not that many, then you have to fill in something called the low volume template.
Okay.
Now, on appraisal, they think you're not doing enough sessions to ensure that you're safe, then that could be an issue. So I can't clearly tell you how many sessions you have to do, but if you're doing less than 40, then you need to fill in the low volume template. In my opinion, you should probably be doing around about that number to keep yourself up to date, because it's less than a session a week.
Yeah.
If you're doing 20 sessions a year, for instance, if you fill in the low volume template and have a discussion, and if you can demonstrate that you're keeping yourself up to date, then you shouldn't have a problem.
And I suppose a similar parallel situation is where somebody's doing quite a lot of work abroad and only some work in the UK. Presumably they can't count the work abroad.
They can't count the work abroad, but suppose you came and did 10 sessions in the UK and you filled in the low volume template,
Yeah.
but you demonstrated that the work that you were doing abroad was equivalent to the work that you do here. For instance, if you work in Australia or New Zealand,
Yeah.
where it's a very similar system to ours, so you'd pretty much be doing what a GP here would be doing, predominantly, not exactly, then you could have enough evidence in your portfolio and in the low work template to demonstrate that you're safe to practice here.
Yeah.
The same also applies, interestingly, Pat, to people that work in the private sector,
Okay.
because they are doing those sessions, but they're not doing NHS sessions. So if they're doing less than 40 sessions, they probably need to fill in the low volume template, but they could be doing...
They could be doing a lot in private. But
private work, yeah.
Okay. Oh, that's really, really interesting. And if you have a period of sickness or some other event which makes it difficult to collect your appraisal material, what should you do about that?
The best and the ideal thing is to contact your appraisal team, and they will discuss deferring your appraisal.
Okay.
And they're generally very helpful, and they can give you an extra period of time to gather your evidence. But the worst thing that you can do is to bury your head in the sand and not contact the appraisal team, because if you do that, then it's considered a missed appraisal. It's not as smooth, but nobody should have any compunction about contacting their local, because they're generally extreme. Our team is they're very nice, and
they'll be understanding.
Very understanding, and they'll be very helpful.
Yeah. Okay. Well, that's good to know. And do people have to include mandatory learning such as life support and safeguarding in their appraisal material?
So now it's strictly not part of appraisal.
Okay.
But it is part of working as a doctor, and obviously a CQC visit to your practice, then they will expect all this material to be there. Most appraisers will ask whether you've done your mandatory training, but they won't check whether you've done it because it's not part of appraisal as such now.
Okay. What's the minimum material that you'd expect to see in an appraisal?
In the appraisal, you're trying to prove to the appraiser that you're safe to practice as a doctor, and safe meaning that you're safe in managing patients, first and foremost, but secondly, you're safe yourself. There's nothing that will impact you that will impact the care of the patients. So now there isn't a mandatory number of hours or a mandatory level of evidence, but most people, they do like to document their educational learning, and the thing is that the appraisal is much more straightforward if you've documented good levels of evidence.
Yeah.
The old 50 hours is a pretty good standard, but I have to emphasize it's not compulsory at that level. I mean, you could do a lot less, and as long as you can justify to your appraiser that you're doing enough to keep yourself up to date. But the most straightforward appraisals are the ones where people have presented a good level of evidence, and increasingly we're putting more store on things like case reviews, in my own personal appraisal material, I like to introduce 2 to 4 case reviews where I'm demonstrating my skills and how I'm using my learning to manage patients and so on. So there's no defined absolute level. There are some things that are very compulsory. For instance, the patient survey and the multi-source feedback from other doctors once in every 5-year cycle.
Okay, yeah.
That's mandatory, but to be honest, that's literally the only mandatory thing there is left.
So the onus is on the appraisee to demonstrate that they're fit to practice.
Yes. And one very important aspect, Pat, is that if you have a complaint, a written complaint or even a verbal complaint from a patient, it's very important to reflect on all complaints and also reflect on the learning that you derived from dealing with that complaint. I have to say that if you don't declare a complaint and it's a particularly significant complaint and they discover subsequently, for instance, from the GMC, that would be a very serious matter.
Okay.
Not declaring it in the appraisal.
You must declare. Okay. And finally, a question that came up at our seminar that we hadn't expected was, how do you become an appraiser?
So what happens is that in each area there is a certain number of appraisers. Normally the appraisers appraise 12 to 15 other doctors. Every so often, with retirements and people changing their roles will come up for appraisal, and then it's a competitive process, it's an interview process, and then new appraisers are appointed, and then you'll be allocated appraisals to do.
Is it easy to become an appraiser?
It is a competitive process, and usually the number of people who want to become appraisers exceeds the number of spots available, but they are trying to get the appraisal pool as diverse as possible.
Yeah, that's got to be a good thing. Thank you so much, Ravi, for talking to us about appraisal today. Really interesting to hear how it's evolving and developing as time goes on, and hopefully your advice can help people, our learners, to make the process as time efficient as possible and to know what they're supposed to be doing now when they go into their appraisal.
Thanks. Thank you, Pat.
Thank you very much. Don't forget you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. I'm Pat Anderson, and this episode was produced by Till Owen. Don't miss next week's episode of the Clinical Update podcast. See you then.